here. This is my third time going to this DSF conference, and it's growing bigger and stronger, and I really appreciate the interactions that I have with the family. And I thank you so much, Kelly, Marianne, and Nicole for inviting me to participate. I hope to be able to answer some of the questions you have all along as it pertains to the infection, vaccination, trigger for seizures, and how inflammation play a role in epileptogenesis. Kara was my very first patient, and she has been and continues to be my inspiration. She's currently 14 years old. She was, I think, 8 in this picture. I look very dark compared to her. A seizure onset was at 6 months, and her first seizure was triggered by immunization. She had a prolonged focal febrile seizures involving either side of the body, and it was the use of lamotrigine that the parents wanted to try. She was on valproic acid, and after reading the scary warnings, they wanted to try to lamotrigine. And I told them, oh, lamotrigine, my absolute favorite medicine that should help your child. And as soon as we switched over to lamotrigine, she started to have a lot more frequent seizures. And it really was parents who alerted me that the seizures were definitely worse, and they were able to communicate that effectively to me, and had the numbers of seizures and how it occurred. As we went up in the lamotrigine and Depakote, we go very, very slowly, and as we increased the lamotrigine, her seizures got worse and worse. And this is what actually motivated me to order SCN1A study and gene testing, and it was became available in November 2004, and Kara was tested on December 2004 and found to have a truncation mutation. She enjoys school very much, has a normal IQ, which has always been an amazing for me. And at that time, 2.5 years of age was early in terms of diagnosis. Piper is my most recent patient. My very first patient I diagnosed when I came to Emory University. Her first seizure was at 6.5 months, and it was very brief, and a referring physician thought this could be Sandifer syndrome, just dystonic posturing with body arching. Second seizure occurred a month later, and which one was a little longer, 12-minute long, with right arm stiffening, fists clenched, and right leg jerking. Eyes were dilated and unresponsive, and was alarming. In addition to the prolonged seizure was the fact that she actually had a weakness on the right side. On seizure 3 occurred only 15 days later, and this time, mom told me definitely it was on the left side, left arm stiffness, left leg jerking, and at this point, it was had a fever. She had a fever, and when I was writing a note, basically summarizing her, and I met her when she was 8 months old. I was writing 8-month-old with prolonged alternating hemiconvulsion with or without fever. And I was like, wait a minute, this must be. And we ordered, at this point, epilepsy gene panel at 9 months of age. And during this time, while we were waiting for gene testing to come back, she had consequent seizures and was admitted to ICU with the status epilepticus. And we found nonsense de novo mutation in SCN1A at 10 months of age. And it's my hope that Piper will do as well as Kara, that we were able to make diagnosis early on before age 10 months of age. So the focus, I highlighted the Kara had seizures with immunization, and Piper, her seizures were definitely provoked by fever. And so the real question is why? I mean, we always think of it as like, sure, it's a trigger. Why is that? Is there something very intrinsic about Dravet syndrome that make them so vulnerable? And I did a literature search, looked for answers, and this was the best I could come up with. And this was just published in April 2018 by Dr. Oven in France. And he is a physician scientist. He noticed that vaccination is a trigger of the first seizure in about 50% in children with Dravet syndrome. And fever remains a trigger for seizures even when the children are older. And what he has done is collected the blood and isolated mononuclear cells and monocytes and incubated them with vaccine and measured cytokine responses. And what you see on the graph is that many of the pro-inflammatory cytokines, notably interleukin-1 beta, TNF-alpha, and interleukin-6, were much significantly elevated compared to control monocytes. And the anti-inflammatory cytokine, interleukin-10, was decreased. Overall, this was a complete switch of the response of the immune cells in children with Dravet syndrome. Really, and in terms of this activation of cytokine and cytokine release, almost appears as if the cells are already primed. And this is the immunologic terminology, where it's as if they have seen it already and responding quickly and much higher level against the vaccine. So there has been some talks about animal models, but I'm going to focus on mouse model and why do we need animal models. And to me, this has really helped us understand Dravet syndrome. There has been this paradox of epilepsy due to sodium channel mutation. We are talking about loss of function of sodium channel. And sodium channel is that when it opens, it causes an action potential. The sodium comes into the cell and it causes activation. And how could loss of function of brain sodium channel, which should be inhibiting depolarization and reduce excitability, cause epilepsy, which is by definition, hyperexcitability and hypersynchronization? That was kind of a, all medical student and resident will ask me, like, that's really unusual. And what happened was that these two studies really, Dr. Catterall's lab, using a knockout mice, and also in Dr. Ogiwara's lab in the knock-in nonsense truncation mutation mouse, gave us the answer. So this is a summary of the Dr. Catterall's lab's work. The sodium channels are specifically reduced and sustained firing is impaired in GABAergic interneurons. So pyramidal neurons versus GABAergic neurons, bipolar GABAergic neuron. There's a selective loss of function in the GABAergic neurons. And this was beautifully illustrated by showing that this is sodium 1.1 was really in a knock-in mice strategically placed in the axon initial segment where the business happens. And they were able to show that there was this negligibly present in pyramidal axon initial segment, whereas it's enriched and paraben positive GABAergic interneurons. So that I think both provided the electrophysiologic and anatomical evidence that the reason for haploinsufficiency, the loss of function of sodium channel, causing hyperexcitability by inhibiting inhibitory neurons. This is sort of double negative. So Dravet syndrome mouse model recapitulates human diseases beautifully. The inhuman onset is before age 1, and it's often immune after vaccination or febrile seizures. And in mice, spontaneous seizures occur within 1 month. So 1 month is about 30 days of age, and most spontaneous seizures occur between 21 to 30 days. So 3 to 4 weeks of age is when the mice start to have seizures, and they are very sensitive to increase in temperature. Hypothermia induces seizures in the mice, and this is an example of slowly increasing the temperature of the mouse by the heat lamp, and you can start to see myoclonus and then generalized tonic-clonic seizures very predictably in mice. And I know there's a Japanese group who have shown that in Japan, there's a family tradition to go to hot bath. And everybody goes into this big hot bath as a family. And of course, the first time they do that when a child is about 6 months old, and that's when they start to have seizures, is what I was told. So it's not just a fever, but your hypothermia, elevated temperature alone is enough to trigger seizures. So in terms of Dravet children, development is normal at seizure onset, plateau or regression in between 2 to 4 years of age, and ataxia. The mice have been known to have some autistic features, and they have shown that cerebellum in the mice are specifically also Purkinje cells involved, and that can cause ataxia. And there's this new understanding of role of cerebellum in cognition. And I wonder if the Purkinje cells were involved, especially in the posterior cerebellar cortex. There is a entity called Cerebellar Cognitive Affective Syndrome, and there is associated with difficulty with modulation of emotions, somewhat of autistic spectrum, but not really autistic. And it's more of the integration of sensory motor function. It's a very special kind of cerebellar cognitive affective syndrome. And I wonder about our children with Dravet syndrome, whether they may be experiencing such syndrome. So CCAS, it's called. Of course, there's an increased mortality with SUDAP, and many of the mice will undergo premature death. And this is highly strain-dependent and depend on genetic background. So I want to tell you briefly about this Dr. Jennifer Kearney's mice. Very beautifully demonstrated the mortality and phenotype is very much dependent on genetic background of the mice. I think it's the clearest example of how there are modified genes that can cause phenotypic differences. So the genetic defects are carried in 129 strain, and they're completely healthy. Nothing is wrong with them. And when they are bred with C57 black 6 mice, the first generation have insufficiency, haploinsufficiency, and they become phenotypically like Dravet. So the F1 are the mice that we use. So she has shown by video EEG monitoring that they start to have seizures around P20, and along with it, there are about over 50% mortality by week 5 of the mice lifespan. So there's a shortening of the lifespan in these mice, and they are only on the F1 strain, not on 129 background. So we use these mice to study the role of inflammation, and I'm going to show you one example. But before that, I wanted to tell you how I got into the role of inflammation. And as a clinician, scientist, I really am always inspired by my patient. And she was 7 years old when I saw her, JJ. She had an in utero left hemisphere stroke, but really did very well except for hemiparesis, no neonatal seizures. But at age 3, she contracted herpes encephalitis. Despite a prompt treatment with acyclovir, she had explosive seizures 5 months later and evolved into Lennox-Gastaut syndrome. She was having epileptic spasms, tonic absence, myoclonic absence, and her seizures were refractory to phenobarbital, carbamazepine, levetiracetam, topiramate, valproate, lamotrigine, ACTH, zonisamide, clobazam, valvamate, and we tried everything. And father told me, you gotta do something. You absolutely have to do something. And she was having 35 to 65 small seizures and 50 to 70 big seizures every day. And we were desperate. And basically, we knew that infection-related seizures not amenable to surgery, but we did this magnetic encephalogram and noted that the spikes were localized behind the left occipital lobe. And it was her case where I was able to take the brain tissue after surgery, were able to do cell sorting and show that in this very epileptogenic zone, we saw infiltration of toxic T cells, highly elevated. This was more than 2 million cells in that area of epileptogenesis. And that I said there has to be some immune mechanism that's involved in this intractable epilepsy. So that's how I actually got into the role of inflammation and immunity in intractable epilepsies. So tell you a little bit about immune cells, because I had to learn myself. These are the monocytes on your left-hand side. Dr. Oben studied macrophages and these polynuclear monocytes in his study, and they are considered innate immunity. The adaptive immunities are B cells and T cells, and the CD4 positive T cells are helper cells. CD8 positive T cells are cytotoxic T cells, and there's also gamma delta T cells and natural killer T cells. So there's this interplay between innate and adaptive immunity. Innate immunity is an immediate responder. Adaptive immunity remembers, they have a memory and will react to it quickly. So they are this peripheral blood, and you know that when we make the diagnosis of genetic diagnosis of Dravet syndrome, they are looking at the nucleus of these cells and make that diagnosis. So every cells carry the sodium channel mutation. So what we do is we get the brain and blood of the patients or the animals, and we'll go through the flow cytometry, and based on their immune fluorescence, we can divide the cells and able to know where they belong, the lymphocytes versus red blood cells, and granulocytes versus monocytes. And we can label the live cells, these are live cells, we'll label them specifically for their space antigens presenting surface, CD8 positive versus CD4 positive T cells. You can tell they have divided into different cell types, and we're able to subdivide them and characterize them very well. So this is the slide that we got from postdoc Dan Zhu, and with collaboration with Dr. Jennifer Kearney, who is right next door in Northwestern University, done flow cytometric analysis of brain tissue from SCN1A knockout and wild-type littermate control mice. And what we saw was there's an increase in microglia. This is important part is that they never had spontaneous seizures yet. These are done, the spontaneous seizures occurs around P20, P21, and these animals were 17-day-old, very young, prior to start of the spontaneous recurrent seizures. What we are seeing is this increase in not just the microglia, which is the innate immunity in the brain, but CD3 positive T cells, cytotoxic CD8 positive T cells, and antigen-presenting cells, the peripheral immune cells, in the brain of the mice before seizure started. This was startling finding. I didn't know what to make of it. Basically, what this tells me is that already in the brain of Dravet syndrome mice, the milieu is pro-inflammatory. They are ready to fire. And that's this prior to initiation of epilepsy. Let me introduce you to microglia. Microglia is like an army on reserve. They're like ready to fight, but they're not yet activated. If they see some danger signal, and this is the only immunocompetent cells in the central nervous system, this is innate immunity in the brain, and they are rapidly activated during brain injury and has this graded response. And compared to the resting microglia with highly branched cells, when it's activated, it becomes stout and becomes deramified. And perhaps for what was important for us to learn in developmental neurobiology is that when the microglia are activated, they're involved in synapse elimination. They not only eat the debris, but during the explosive development, about 6 months in babies and in first year of life, or in animals, first month of life, there's explosive synaptogenesis and there's a pruning that occurs, and synapse synthesis is driven by astrocytes, but synapse elimination is done by microglia. So you could imagine when microglia is activated, it may cause eating up of those synapses. Something to think about in terms of how it will affect cognition. So what we use is what we call green mice, CX3CR1 positive GFP mice, and these labels microglia. So all you have to do is actually, in order to look at the microglia, you can just look under the microscope, and you have this green cells. It reminded me of the stars in the dark night. They are everywhere in the brain. And what we noticed was when we induce seizures in young animals, and then we give them another hit of seizures later in life, there's this exaggerated response of microglia. So the A is the saline versus kainate, versus the B is kainate, meaning got 2 hits about 2 weeks apart. So the early life seizure increases micro response to the second seizure and in the later in life. So that seizure susceptibility is also correlated with microglia activation. So they're more likely to have seizures early after injection of kainate, which is the seizure-inducing glutamate analog. So what we have done is after first seizure, we treated with anti-inflammatory medicine with its anti-microglia activation, minocycline, and what we saw was it reduces the seizure-induced microglia activation, but more importantly, when we then treat them, when we hit them again with the second seizure, the microglia activation, the exaggerated response was diminished, and at the same time, seizure susceptibility was also gone. Thinking that inflammation perhaps causes this priming effect, so that every seizure is more likely to have second seizure I always say the brain become more vulnerable or more susceptible to the second seizure. And this is the part that I enjoy most. It's I went to summer camp with children with epilepsy, and there they start to make friends, and many of them had been very isolated, but in the summer camp, it was okay for them to have seizures, and they formed a wonderful relationship, and by the end of 7 weeks, they have formed really friendship that lasts for longer than 1 week. So I started this, what I call summer camp for rats. And this is where they are. They stay together. Please work. So they are housed together and 8 animals together, as opposed to isolation. And these are animals that were housed after seizures. And what's going on with them is that if they become incredibly anxious, and they will jump and be very, very jumpy after seizures. But if they had each other and they will be playing with each other, they interact, not just this playful cages, but what's important is having each other. And it has a profound effect on them, such that I gave you that idea of 2 hit. After first hit, if they're in the environment enrichment, the lower threshold was normalized by the enriched environment. So their vulnerability was no longer there. And along with it, what we saw was this seizure-induced increase in inflammation-related genes, such as AIF1, complement QB, CD48, CD53. These are all decreased by environment enrichment. And this is the green mice, where microglia is highly activated. And if the animals were isolated after seizure, they have this persistent activation of microglia, whereas they are completely normalized within 10 days after first seizure. So, And we were seeing this in hippocampus, in the lateral septum, in amygdala. So even more powerful than minocycline was this enriched environment. And this is a powerful anti-inflammatory. And there have been some questions that were thrown about what is the role of occupational therapy and physical therapy, and the swimming. And I really think that's part of the environmental enrichment that could really normalize the inflammation that's induced by seizures. So what little curious have taught us is that SCN1A mice recapitulates many features of Dravet syndrome, and it's a pretty clinical platform to test new therapeutics in addition to zebrafish, I think, and it can predict and prevention of the SUDAP, and the dysfunctional GABA inhibitory circuits is sufficient to cause seizures, and this has been born to this interneuron hypothesis of Dravet syndrome, and the severity of disease is very much influenced by genetic background, modifier genes. And the pro-inflammatory milieu in Dravet syndrome that we saw in the peripheral blood prior to clinical seizure onset, we saw in the Dravet mice that there's increase in microglia, antigen-presenting cells in the brain, the innate immunity, and there's also infiltration already of a cytotoxic CD3, CD8 positive T cells in the central nervous system. And I shared with you the anti-inflammatory action of enriched environment. And in addition to that, perhaps some immunomodulatory therapy could be helpful for Dravet syndrome. Thank you very much.